This is Chapter 38 of NUR 203, Family-Centered Care of the Child During Illness and Hospitalization. You can read your objectives and follow along with them and check them off. Make sure we cover everything if you like. So, stressors of hospitalization and children's reactions. The major stress from middle infancy through the preschool years, especially 6 to 30 months of age, is separation anxiety. If you look on page 1048, box 38.1 tells you of the manifestations of separation anxiety in young children. And there are 3 phases, which you can see here. In the protest phase, there's crying and screaming and clinging to the parent and turning away from the person trying to take them. The despair phase, they stop crying and there's evidence of they're just depressed now. Detachment phase is denial, resignation but not contentment, and the possible serious effects on attachment to parent after separation can be lifelong. Here you see the protest phase of separation anxiety. The child is crying loudly and inconsolable in their grief for the parent. This picture's during the despair phase of separation anxiety. Children appear sad and lonely, and they're not interested in food or play. They're just sad. In this phase, the young child appears withdrawn and sad even in the presence of the parent. This baby's mad at mama because she left him or her, whatever that is. Early childhood separation anxiety. If separation can be avoided, then children can withstand many other stressors. Babies and small children will be more cooperative and recover faster when family is permitted to room in and stay with the child. Older children and adolescents just want their friends to visit and talk to their friends on the phone. They don't necessarily care that much about the parent being around unless it's maybe the first time that the teenager's been in the hospital and they're a little apprehensive about what's going to happen. They may want their mother to stay at least the first night. Late childhood, family does not play as important a role as the peers, but you got some kids who are still going to want their mama to be with them, like I said, at least the first night. Loss of control increases perception of the threat, affects coping skills. Overwhelming stimuli like slow or restrict their growth. Lack of control can increase the child's and the parent's stress levels. It increases their perception of threat and affects their coping skills. Altered routines and rituals makes everybody more anxious, and we fear the unknown, and that's just normal for all of us. So, effects of hospitalization on the child. Parents may need to be reminded that the sibling is upset about the child being ill, and they also require more love and attention during this time. Keeping the sibling informed and letting them visit if possible will be helpful to the sibling. Effects may be seen before admission, during hospitalization, or after discharge. Like I said, fear of the unknown can be very frightening, so for a very young child, 1 to 2 day notice is sufficient that they're going to have to go in for a procedure. Many hospitals have nurses who do a program that walk the child and the family through the unit, where the child's going to be, and show them what to expect. And that kind of helps to alleviate the fear aspect so much. Individual risk factors. Children who are active and strong-willed do better with hospitalization than passive children. Rural, like country children, seem to be more clingy or more upset than the urban, cityfied children. Children under the age of 7 may have regression, separation anxiety, apathy, fears, and sleeping disturbances while hospitalized. I've been cussed out by more than one 2-year-old in my pediatric nursing days, and the eye rolling and ignoring you when you come into the room, especially from male children. It's kind of interesting, the dynamics that kids have. Many of my pediatric patients were what we called frequent flyers, meaning that they had chronic illnesses and needed to come back and forth to the hospital for treatment frequently. So they kind of got used to the routine, and some of the nurses were their favorites. Shorter hospital stays and home care has become more of the norm for all patients within the recent years. If they stay longer than a few days now, it's because they have something very serious going on. We all know that the hospital is a good place to get sick, so get in and get out is probably a good idea. Technologic advances are helping even the smallest preemies now, or more seriously injured children, to get discharged faster. And we need to focus on the child's psychological wellness and how they handle being hospitalized to make sure they stay happy and get healthy faster. Beneficial effects of hospitalization. The most obvious benefit to hospitalization is to get well. Without special attention devoted to meeting the child's psychosocial and developmental needs in the hospital environment, the detrimental consequences of prolonged hospitalization may be severe. So they need to learn to master their stress and make new socialization experiences, and the nursing strategies have to be on point to help these kids to recover as quickly as possible. Stressors and reaction of the family of the child who's hospitalized. Parental reactions, overall sense of helplessness. When my children were sick, it was like I didn't know what to do with myself. Even when I was a nurse and a pediatric nurse, it still made me feel helpless. Questioning the skills of the staff. We all want the best nurses for our children, so we watch them. Being nurses, we know what's expected that they should be doing, so we're more watchful of that. Accepting the reality of hospitalization, dealing with the fear, coping with uncertainty, and seeking reassurance are all important factors. Sibling reaction, again, experiencing many changes and being too young to understand them. It can be confusing to the siblings. Being cared for by non-relatives or outside the home because mom and dad have to be at the hospital with the sick child kind of makes them a little resentful. Receiving little information about the ill brother or sister can also make them fear more that something's terribly wrong, and perceiving that the parents will treat the sick child differently. They want as much love as the sick child is getting, and that's understandable. Preparation for hospitalization. We need to prepare the child in advance for admission. Like I said, the younger the child, the fewer days notice you need to give them so they don't have time to really get scared over what you just told them. Preventing or minimizing separation by staying with the child and rooming in with them. Any family member, I think, is pretty much allowed to stay. Doesn't have to just be the mother or the father. Preventing or minimizing parental absence. If the parents need to go down and get a cup of coffee, the child is sleeping, certainly we're going to watch them a little more closely than if the parent was in there with them. So usually the parents will come and tell the nurse if they have to leave the floor for a minute to get something to eat or a cup of coffee, and we'll be aware that if they woke up, they might be frightened. Minimizing loss of control, promoting freedom of movement, maintaining the child's routine, and encouraging independence in industry is important. Depending on the developmental age of the child, we need to think about all that, all of Erikson's stages of development, and put that to work for us. Preparation. The initial admission procedures give the nurse an opportunity to get to know the patient and assess his or her understanding of why they're being hospitalized and what's going to happen. This is just a little chart here of Eric's daily schedule. Knowing a child's regular routine can be helpful, and trying to mimic their routine, though, can be difficult when in the hospital because we have other patients. So we can't always keep them on their same schedule, but we can try as closely as possible. This is a child drawing and painting, and that's an excellent media for their expression. Looks like they're in the playroom, and in the playroom is a safe place in the hospitals. On pediatric units, they have what's called a playroom, and that's where the child life specialist and volunteers will have the children go that are able to go and play, where they feel safe and nothing can happen to them bad there. If the nurse needs to give a medication or restart an IV or draw blood, we will remove the child from the playroom and take them to a treatment room where we can do what we have to do. And then they can return, perhaps, to the playroom and feel safe again. This is a volunteer, or the child life person here. A child life specialist is known as a play therapist. It's a bachelor degree program, and anybody can do it. You don't have to be a nurse. You get paid good money to play with the sick and injured children all day and manage their hospitalization and try to make it better for them. It's a very important job, and the children learn through play as well as cope through their distractions. You can see about that at http://www.childlife.org and see what it takes to be a child life specialist. Play materials for children in the hospital must be age appropriate and geared to their interest and their limitations. If they're on bed rest, then they have to be appropriate for bed rest. Nursing care of the child who's hospitalized. Some home situations like abuse, neglect, or other negative behaviors, problems with feeding, potty training, and bedtime routines can be altered during hospitalization, and this gives the parent a chance to seek help for things that they may realize need to change in their homes. Nurses are always teaching, and if asked for help, we can enlist a social worker or other people in the hospital community to assist the parent to learn a new way to cope or deal with their problem. While in the hospital, the child may get to test the fantasy versus reality fears and understand that they are not going to be abandoned, mutilated, or punished, and that they are in fact loved and respected for their concerns. Giving them choices to make, even if it seems small, will let them know that we value their opinions and encourage them to express self-mastery skills. Placing children of about the same age group together also gives them time to socialize and decompress their fears and anxieties. Then we have preparing the child for admission. Keeping the parents informed as much as possible about what's happening to their child will make them very happy and cooperative. Discharge teaching always begins on admission to the hospital, and it's an ongoing process throughout their stay. As we get orders and we see their recovery happening, then we can teach more about what they're going to need to do when the child gets home. We need to avoid needless anxiety, establish a trust between the child and the parent with the nurse, and room selection can be important. The child that they're in the room with needs to be as close to their age as possible so they have things maybe in common to talk about. Nursing interventions, preventing or minimizing separation, parental absence during infant hospitalizations should be also minimized. When a child or baby is sick, they don't want nobody but mama. And although we're a good substitute with our nurturing skills, it's still not the same as mama being there. Minimizing loss of control, we talked about that. Promoting freedom of movement, maintaining the child's routine. This is kind of a repeat of what we just got through talking about. Preventing or minimizing fear of bodily injury. We don't do anything we don't have to do to the child, but if they keep pulling out their IV, we're going to have to keep putting it back in, so they need to come to an understanding about that. Playing dress up with gowns and masks so the child will understand when people come into an isolation room wearing these things, and explaining why the germs must be kept out so that they can get well and go home just stands to reason. And most children are very understanding and eager to learn about these things, and they'll be very watchful of people entering and exiting the room. People coming in, they will tell them, aren't you supposed to have gloves and gown and mask on? Y'all need to get that stuff on. And then if they don't wash their hands when they leave the room, they'll call them out on that too. Fostering parent-child relationships, providing educational opportunities, promoting self-mastery, and providing socialization, I think we pretty much covered. This is a picture where we were like placing children of the same age group with similar illnesses near each other on the unit is both psychologically and medically supportive. Supporting the family members, providing them information, encouraging parent participation, and preparing for discharge and home care. Again, that's just reiterating what we've already talked about. Ambulatory or outpatient setting. This helps minimize stress of hospitalization. It reduces chance of infection. It's a big cost savings over having them admitted to the hospital for overnight or longer. And it's most frequently used for surgical or diagnostic procedures, day surgery and stuff like that. Isolation is an added stressor of hospitalization. It limits the child's, there may be limitations to the child's understanding of why they're being isolated. It depends on their age and how much they can understand what you're explaining to them. We need to deal with the child's fears. In doing that, somebody probably needs to stay with the child. Potential for sensory deprivation and environmental changes. They can't go to the playroom, so the child life people and volunteers will come in and play with them. Emergency admissions are always the most scary. It's the most traumatic of all hospitalizations. There's little time for preparation because of the sudden onset. Overuse of emergency departments is something we can't help nowadays. I mean, if your doctor's office is closed and you need to take your child to the doctor, if you can't get them to a Solantic or a freestanding clinic somewhere, then you take them to the ER. Participation of the child and family as appropriate to the situation, also important. Intensive care units, child's and parent stress level is super duper increased. Emotional needs of the family must be met as well as the child. The parents need to keep them informed. That helps tremendously to decrease their anxiety and fear. Critically ill children become the focus of the parent's whole life. Their world kind of stops when their child is in the intensive care unit. This is a picture of a baby. Looks like was in an intensive care unit. The parents are bonding with here. And your question says, during the first 4 days of hospitalization, Eric, aged 18 months, cried inconsolably when his parents left him, and he refused the staff's attention. Now the nurse observes that Eric appears to be settled in and unconcerned about seeing his parents. The nurse should interpret this as which of the following? Is it A, he has successfully adjusted to the hospital environment? B, he has transferred his trust to the nursing staff? C, he may be experiencing detachment, which is the third stage of separation anxiety? Or D, because he is at home in the hospital now, seeing his mother frequently will only start the cycle again? Well, of course it's C. He may be experiencing detachment, which is the third stage of separation anxiety. And that concludes this chapter. Thank you.